Thanks for inviting me to this meeting. I'm going to spend the next few minutes to talk about non-alcoholic fatty liver disease in Nigeria, using the following outline. Well, by way of introduction, non-alcoholic fatty liver disease is a spectrum of both pathological and clinical conditions that describe accumulations of lipids, mainly triglycerides in the liver. This occurs in the absence of significant alcohol intake with fat greater than 5% of liver weight. It ranges from simple steatosis to steatohepatitis, fibrosis, and cirrhosis. It is the hepatic component of the metabolic. It is the commonest cause of chronic liver disease in Western countries due to high prevalence of obesity. NAFLD, for short, was previously believed to be benign, but currently is known to progress to cirrhosis and liver cancer. It's been attributed to due to changing lifestyles and more awareness of NAFLD in Nigeria. The prevalence is increasing, especially among type 2 diabetics. A subtype of NAFLD, NASH, was coined by Ludwig et al. In 1980. In terms of epidemiology, it is the most common liver disease worldwide and affects about 25% of the world population. It is very common in developed countries. About 75 to 100 million Americans were affected in 2017. And NAFLD is the leading cause of chronic liver disease and the second most common indication for liver transplantation after cirrhosis caused by hepatitis C. In Europe, 25% of people are said to be affected, and it accounts for an annual economic burden of about $103 billion in the US in 2016. Let's come to the Nigerian situation. Not much studies have been done on NAFLD compared to the Western countries, but Onyekwere in 2011 found a prevalence of 8.9% among 150 subjects. These are hospital subjects, 55% of whom were females. The prevalence was high among the diabetics among them. Olusoya in 2016, in a study of NAFLD among type 2 diabetics, found a prevalence of 16.7%, compared with 1.2% among the non-diabetic controls. Anthony Wojo in 2018 in South Nigeria reported a prevalence of 25% among 300 subjects, with higher prevalence in diabetic patients than non-diabetic subjects. She noted higher components of metabolic syndrome among the NAFLD subjects than those without NAFLD. Similarly, Chukwura et al. In 2019 also reported high indices of metabolic syndrome among chronic liver disease patients in Southeast Nigeria with NAFLD than those without NAFLD. Odenibo, also in the same hospital, found a prevalence of 31% among 102 subjects studied. What are the risk factors implicating the NAFLD? Obesity, type 2 diabetes, hypertriglyceridemia, metabolic syndrome, total parenteral nutrition, obstructive sleep apnea, rapid weight loss, PNPLA3 gene, gut dysbiosis, overnutrition, and fructose consumption have all been linked to occurrence of NAFLD. In terms of clinical presentation, they are generally asymptomatic, usually detected during unrelated abdominal ultrasound or liver biopsy. In some cases, symptoms are related to liver dysfunction such as fatigue, malaise, dull right upper quadrant pain, and jaundice. The commonest clinical findings and examination is mild to moderate hepatomegaly and is said to be the commonest cause of unexplained hepatomegaly. In terms of pathogenesis, it's thought to be multifactorial, involving the interplay of complex mechanisms. Currently, the multi-hit theory defines the mechanism of NAFLD: abnormal lipid metabolism. Obesity and insulin resistance leads to an increased free fatty acid flux, resulting in the excess fat deposition in the liver, causing and oxidative stress. Glucose metabolism excess glucose is converted to free fatty acid. This is encouraged by hyperinsulinemia. Dysbiosis of the gut has also been implicated and leads to gut-derived lipopolysaccharide, which is a component of gram-negative bacteria, stimulating a chain of changes including insulin resistance, increased hepatic oxidative stress, metabolic dysregulation, and fibrosis. Visceral adipose tissue has also been implicated. It produces adipokines, which modulates insulin sensitivity. With respect to diagnosis, based on alcohol consumption of less than 30 grams per day for men and less than 20 grams per day for females, gold standard for diagnosis is liver biopsy and histology, but we know liver biopsy is invasive and associated with sampling error, hence the limitation. Ultrasonography, computed tomography, and magnetic resonance imaging all detect various degrees of fatigue. Ultrasonography is the screening modality of choice. It is widely available and cheap with a sensitivity and specificity of about 84.8% and 93.6% respectively. Most studies reported in Nigeria were ultrasound based. There is none of these studies was based on histology. Transient elastography is a newer modality in assessing modality. It's portable, could be used for population studies, but it's expensive. Other investigations include liver function tests, complete blood count, viral screening, fasting blood sugar, and lipid profile. Treatment relies on lifestyle modification, dietary restrictions to about 500 to 1,000 calorie deficit, weight loss of about 10% of body weight within 6 months, aerobic and resistance training of 150 to 200 minutes per week in 3 to 5 sessions, low to moderate fat, moderate to high carbohydrate intake, avoidance of fructose, and low carbohydrate ketogenic diets or high protein Mediterranean diets have all been found. In terms of drug treatment, it's reserved for patients with non-alcoholic steatohepatitis. There is really no guideline approval of any drug therapy, but off-label treatment have been discussed need to be discussed with the patient. And the drugs that are currently being used and found are metformin, pioglitazone, vitamin E, incretin mimics, statins, silymarin have all been tried. Patients with non-alcoholic steatohepatitis, ursodeoxycholic acid or urbatic acid must be used since they inhibit apoptosis. However, liver transplantation may be recommended in some cases. For patients unresponsive to both lifestyle and drug treatment, bariatric surgery is a good option. In summary, non-alcoholic fatty liver disease has become a worldwide health concern with increase in global incidence of obesity. Though not much of this have been done in Nigeria, available reports indicate high prevalence ranging from 8.7 to 31% with higher prevalence in diabetics. Also, indices of metabolic syndrome were reported more in NAFLD subjects than those without NAFLD, even among patients with chronic liver disease. This in line with the reports globally. These findings may not be unconnected with the changing lifestyle and adoption of Western diet and sedentary lifestyle by Nigerians. Treatment remains lifestyle modification, including weight reduction, reduced calorie intake, and off-label use of metformin, pioglitazone, vitamin E, especially in cases of NAS, non-alcoholic steatohepatitis. Ursodeoxycholic acid has also been found useful in some instances. Thank you for your audience.